Hello, everybody. Thank you so much for being here today. I did not expect this kind of turnout, so excuse my nervousness. I'm not used to talking to everybody. As she said, I got to present at Sigma Theta Tau Congress in Singapore. The title of my presentation and the title of my integrative research review was The Effects of ECMO, which is extracorporeal membrane oxygenation, versus conventional ventilator management on adults suffering ARDS, which is acute respiratory distress syndrome, an integrative research review. So here we go. All right, so we just got through the introduction, so we're almost done, don't worry. I'm gonna give you my poster presentation, what my experience in Singapore was like, kind of just a preview of what's next for me and for Covenant for our ECMO program, and then I'm happy to take any questions at the end. This is my lovely family who's in the back, Tabitha, my wife, my daughter Abby, and Matthew, my son, who's grinning ear to ear. Without them, I definitely would not have been able to make it through the program, much less through working through COVID, and you guys know how it is balancing schedules on lives and families. And this is my other family, the ECMO team. This is an older picture. This was right after COVID that this picture was taken, so we've lost some and gained some, but we have about 10 more bodies than what's represented there. Right now we have a total of 30 people on the team. That includes 3 perfusionists, myself and Midge, who are the advanced ECMO specialists. She's our head ECMO coordinator. And then whatever the math adds up to be, I think 25 ECMO specialists that sit with the patient and the pump at the bedside. Wonderful team. We're integrated. We're a mixed team from Children's Hospital and from the adult campus. PICU nurses, a couple NICU nurses, a bunch of SICU nurses, and some RTs from both campuses as well. Here's my poster. Since it would be really hard to give my presentation off of that on the screen, Dr. Long had the great idea to split it up into slides. So let's just kind of start from the beginning. What's ECMO? ECMO isn't a standard level of care that you see every day of the week. It's reserved for the sickest of the sickest patients. For my study specifically for acute respiratory distress syndrome, there's 2 different types of ECMO. VA ECMO, which is venous arterial ECMO, that supports the heart and the lungs. My research focused on VV ECMO, which is veno-venous ECMO. And so that's only supporting the lungs. It means their heart is doing okay, all they need is lung support. So not quite as sick as your VA population. Let's see. It is a highly invasive form of life support, carries many risks along with it: hemorrhage, risk of infection, risk of not being able to save them, so death. It doesn't fix anything. It's a form of life support, and it's a bridge to something else. It's either a bridge to buy time for your body to recover itself. It's a bridge to a transplant program. Since there's not a transplant center here in our region, then we'll be referring those patients out, or is a bridge to a decision. Sometimes that decision is end-of-life care and decannulation for that purpose. But ECMO itself doesn't fix the patient, but it buys plenty of time for the body to recover. Just kind of a side note, because these patients are so sick, and we'll talk a little bit more about it later, when they go on ECMO, that means that up until that point, you have about an 80% chance of mortality. So you're only looking at the patients that are so sick, they have about a 20% chance of survival before they go on pump. This is a picture of what VV ECMO looks like, and that's the same CardioHelp system that we use with the oxygenator. This is a typical cannulation setup for our adult patient population. You'll have a large drainage cannula in the femoral vein, and then your return cannula giving the oxygenated blood back on VV ECMO is in the internal jugular vein. If this was VA ECMO, then you would have a drainage cannula in the vein, but you would be returning to one of the arteries, either the carotid artery or to a femoral artery. The other setup we use for VV ECMO for adults is just one giant cannula in the jugular vein. Somebody my size, and these cannulas are huge. Somebody for my size, if we were to do that setup, the cannula in my groin would be 23 French, which is huge considering a central line is 7 French, right? Even your biggest catheters like your trialysis line, the bigger size of the trialysis power injector That's a 13 French. So you're putting 21 to 23 French in my groin and putting either a 19 or a 21 French in my neck. Very large cannulas. Bleeding is a huge risk. If it was the single cannula, dual lumen site, then for somebody my size, it would be a 31 French dual lumen cannula in the jugular vein. So, risk to go on ECMO, humongous. Going on ECMO, the surgeon cannulates under fluoroscopy or under x-ray because the risks include perforating through the atrium and ventricle, perforating through the vessels while they're cannulating, tearing the vessels if they're not quite big enough and they can't accommodate the size. So, not something we just throw people on every day of the week, right? My research question was, in adult patients suffering ARDS, what's the effect of ECMO versus conventional ventilator management on mortality? The methods we used in our research class with Dr. Long included the textbook from Brown from 2018, and then my supplemental textbook was Burns and Grove. That was way back from 2009. Databases included Cochrane, Cinol Plus with full text, and Medline Complete. My search terms took me forever to get right, but that is the big jumbled up mess that when I copied and pasted into every search tool, gave me the results that I needed. I'm not going to read that whole thing because it's really just a jumbled up mess. But it got me all my sources that I needed, so I was really excited about that once we came to that conclusion with lots of help from Dr. Long, obviously. Databases were limited to English because that's the only language I speak. Full text because you need to read the full text to be able to do a lit review, right? The adult population, there's a lot of data out there on the pediatric population, but since my main background is adults, I really wanted to focus on adults. Cochrane was limited just to Cochrane reviews because I was really trying to find a really solid level 1 gold standard study since Cochrane is amazing. Cinol was limited to 2018 to 2023. And Medline, initially I had a larger range of dates, but the articles that I really liked were all from 2021, so limiting to that year got rid of some of my articles for me at the same time. Make sure I'm going the right way. I understand that there is an updated Prisma diagram now, but this is the one from 2009 that we were using just last year when I took the class. I ended up with 71 articles and 2 through bibliography mining, 2 duplicates out of the 71, so that brought me back down to 71. So all 71 of those articles were, I'm very hands-on. I had to print them off and read them, so I printed them off, read them, took notes, and 58 were able to be excluded either from being the wrong population, because a lot of articles were for pediatrics, or it was a single patient study, or not good data, you name it. But I ended up with 13 articles total. Did I go the wrong way? Well, background, okay. So the background and significance, so acute respiratory distress syndrome, worldwide, you average about a 50 to 60% chance of mortality just from having that diagnosis. To get an ARDS diagnosis, that's talking about your PF ratio. So if you draw a blood gas on a patient, if your PaO2 divided by the FiO2 is less than 400, you're considered to have some version or form of ARDS. So we all should be sitting with a PaO2 of 85 or so, right? Divide that by 21% oxygen, you get just over 400. So congratulations, we don't have ARDS. If there was somebody on oxygen in this room, we could ask them what their percentage was and we could determine what level of ARDS they have sitting here with us, but they don't. Different levels include, so if you're just under 400% on your PF ratio, that's just considered hypoxemia. Under 300 is considered respiratory failure. So those are going to be some of your patients that are going to be on either BiPAP machines or really high levels of mid-flow settings. Under 250 is severe respiratory failure, and under 200 is critical respiratory failure. Your severe and your critical respiratory failure patients are going to be your standard ventilated, sedated patients that you see every day in the ICU. VV ECMO, like we I kind of walked you through earlier. So it acts as a shunt. So you taking blood out of the vein, oxygenating it. You have a sweep gas, so you can adjust their CO2 levels, you can adjust their pH, and you're giving it back to the patient fully oxygenated. So that way you can come down on your aggressive ventilator settings, let the lungs rest, and their body can be happy because you're oxygenating them with your ECMO circuit. VV ECMO is used as rescue therapy for the sickest patients that remain hypoxemic despite all the patient optimization you can try. You can prone them, sedate them, paralyze them, use inhaled nitric oxide, use everything under the sun that you can. A lot of times that works on them, right? But for the patients that don't respond to standard therapy and treatment, we have ECMO. Clinically, at our hospital and worldwide, ECMO starts getting talked about when their risk of mortality is around 50% and their PF ratio is under 150. And it's indicated, meaning they need to be on ECMO or you need to be getting ready to put them on ECMO if their mortality rate is 80% and their PF ratio is under 80. So having your whole class of ARDS and your sickest ARDS patients are under 200, it's the sickest of the sick that are under 80 on their PF ratio that are really considered for ECMO. If a patient has a PF ratio of under 80 and they're not doing anything about it, more than likely it's because they don't meet criteria to be an ECMO patient, which we can touch on later. So sorry, I switched my notes too soon. Okay, literature synthesis. So in the mortality of patients with severe ARDS, most of it is due to ventilator-induced lung injury. Too much pressure, too much volume, too high of an FiO2 causes scarring, causes volutrauma, causes barotrauma. All that kind of gets lumped in under ventilator-induced lung injury. Any FiO2 above 60% will eventually cause scarring to the lungs. Midge, and they know Midge, our ECMO coordinator, her saying is always, FiO2 above 60%, that's like sending a flamethrower down the ET tube to scar their lungs up, kind of to put it into perspective. So treatment for ARDS, you're going to want to decrease the tidal volume, decrease the amount of pressure. You can prone them, you can paralyze them, take all the pressure off the body so their lungs can get better. You can't do that without ECMO if they're not responding to your typical treatments, and so that's why ECMO is there, to be able to oxygenate them and let the body rest and take care of itself. There was a huge uptick in ECMO patients with the H1N1 pandemic in 2009, and with COVID-19, massive influx of ECMO patients during that time period. Let's see. So ECMO is what provides the gas exchange. So ventilator support can be minimized so your lungs can rest, so your lungs can heal. Throughout all the articles that I looked at, everybody in their own way really focused on proper patient selection being very important to the patient's survival. During COVID, that became even more important because during COVID, all the ECMO centers in the country were having to triage their ECMO beds. And so if you had a typical patient who was maybe a little too old or a little too obese, they wouldn't be able to go on ECMO because somebody else met better criteria. That criteria being during COVID, the age plus BMI had to be 65 or under to be considered for ECMO. So very strict because there weren't enough ECMO centers or enough beds. And it got to the point to where there were bigger centers calling us saying, hey, we don't have an ECMO bed, but there's a patient in Midland that needs ECMO bad. Can we send our transport, like they have a portable cannulation team. We're gonna fly to Midland, cannulate them in Midland, fly them to your hospital, and you guys can take care of them until we have a bed open, and then we'll bring them back with us. So there was a lot of inter-hospital, all over the country, everybody was talking to each other about ECMO beds because so many patients needed it. One of the studies, I thought it was interesting, they used the Uden's index method to predict their survivability. We use the RESP score on mdcalc.com to predict their survivability once we put them on ECMO. But there's lots of tools out there to predict survivability. ELSO is an organization that's been around since the 90s, and they collect data on ECMO patients worldwide. Not every ECMO center has to submit data to them, but most of them do submit data. From the 90s up until 2023, the total runs worldwide that's been submitted to ELSO is 56,581 adult pulmonary, which would be VV, so my population for my study, total runs. Those who survived ECLS, 66%. The ones that survived to discharge or to transfer, like to a SNF or to rehab, 59%. So you're taking people with a 20% chance of survival, and from the 90s up until now, almost 60% chance of those people are surviving. I say that because in my study, there wasn't statistical significance showing the benefit, but once going back and reviewing, it's because those numbers were based off of the overall picture of ARDS. All those patients, even the ones just on 4 liters nasal cannula, were getting lumped into that 50 to 60% survival compared to just the super severe cases who really had a 20% chance of survival. So even though the statistics didn't work out in my study, it's still clinically significant, and it's helping people, even those who are very, very ill. So clinical implications, ECMO is a very high-risk treatment, but done well on properly selected patients can really benefit them and their families because it can keep them around. When they meet criteria for ECMO, quick escalation of care is important to prevent a ventilator-induced lung injury. And one of the calculators that we use is called a RESP score to calculate survivability of an ECMO patient. I put myself in there, so me at 32 years old, if I just had super severe ARDS and they wanted to put me on ECMO, if I had been on mechanical ventilation for 2 to 7 days, my survival would be 57% if everything else was clinically perfect. If they got me on ECMO within 2 days of being intubated, my survivability shot up to 76%. So time really matters. When you identify the super sick patients that need ECMO, because proning, paralyzing, medications, everything else isn't working, then we really want to see them get transferred to an ECMO center. We get a lot of transfers from other facilities for potential ECMO, especially if it's for a car accident. If they have really bad pulmonary contusions, we've had people transferred to us for that before. Now, if they go on or not, we hope we don't have to put them on, but if we do, at least we have the tools available to do so. And ECMO carries many risks. You know, you have garden hoses in your thigh and in your neck. Bleeding is a huge cause of concern, infection, but it has been shown to be successful in saving multiple patients' lives. A lot of us have seen that firsthand, especially at the Children's Hospital. We had a really good winter where we got to take care of a lot of kids. And during COVID, we took care of a lot of adults, and one of them that survived just the other day that would have passed away, he had a daughter. Another one is finally off of his oxygen. And so, like, these people are more than just numbers when you're there at the bedside with them, right? And so, it's great. So, in my conclusion, all 13 of the articles in the summaries said something about we need some randomized control trials to really study ECMO. It's easier said than done. There's only been 2 trials to date so far. One huge issue with having a randomized control trial is you can't really do a true study ethically and morally if you lump a patient of groups in, nope, they're not going to get ECMO, even though you have ECMO capabilities, and you can just see what happens. Or these patients are going to get ECMO, and even with optimal ventilator management and everything else, you may not need it and so if you're taking patients and you're putting some on that you can avoid, you can cause a risk of complications from ECMO. If you're taking some and they need ECMO, and you're saying, nope, we're doing a controlled study, we can't do crossover, there's a lot of flip-flop back and forth. With the flipping and flopping and going back and forth, those patients that spent longer time in the non-ECMO groups had a higher mortality than those who were designated for ECMO right off the get-go and were cannulated sooner. So that also helps support that time really matters in the end, but it's hard to do a solid study that you can get truly accurate data from, and proper patient selection. So getting to share this with everybody in Singapore was a whole lot of fun. There were over 1,000 attendees at the conference, 47 countries. Most of the participants were from the US, then Taiwan, Korea, China, and Singapore. What was hard for me was 65% of the attendees all had doctorates of some kind, and I wish they would have published the data on it. I would have really loved to see how many presenters had a doctorate of some kind as well. Because on my row of posters, I was the only person with an MSN, and everybody else I was talking to was DNPs and PhDs, and that was pretty intimidating. Really intimidating, because you know, you're all sharing information, and they're like, oh, where do you teach? It's like, no, I don't teach, I'm bedside. But they really respect your opinion, and they really like to look at your poster. And I want to thank LCU, Dr. Long. All of the posters that I saw in my class, you can go toe-to-toe with anybody there. The posters that they teach you how to make are so well planned out, so well executed, so well organized. Not for me, but because of the way that they taught us how to do it. There were more than one professor there that took a picture of my poster, not because they cared anything about ECMO, but because they said, how did your professor get you to make your poster look like this? This is what I'm trying to teach them, but they're not listening. And so to be able to share kind of with like, yeah, well, welcome to Texas. We do things big. But it was nice to be able to talk to everybody and collaborate with them and see what other people are passionate about. Yeah, so it was a whole lot of fun. My wife got to go with me, and the kids stayed here. And Singapore was beautiful and amazing. It was just super lush and humid and hot, but in a pretty way at least. Got to meet all kinds of people. Those were some people from Taiwan chapter that were there. The airport, I mean, you get off the plane and the world's largest indoor waterfall is inside the airport. How cool is that? I took a picture of this, and I was afraid it wasn't going to be very clear, so I wrote it down. That presentation, one, she had a great presentation, but these are the kinds of people you're up against. It was her name, and her credentials are MD, DNP, MPH, MSN, APRN, NPC, PHN, CCRN, FNPC. Yeah, those are all of her credentials. And so you're talking to a lot of people who are very, very highly educated, but when it comes down to it, whatever you're passionate about, and you're given the tools the LCU is giving you, you can go right up there with them and have a conversation. You're talking the same language about how your study was formed and how you looked at how you graded and how you determine levels of evidence. You're all speaking the same language. So it was really, really cool to see that you could have a conversation with somebody so smart as that. And then this was the national dish of Singapore, chicken and rice, and it was incredible. We ate it everywhere we went. We even had one last bowl of it right before we got on the plane to come back home. What's next for us is we're continuing to grow the ECMO program at Covenant Medical Center and specifically the Children's Hospital. We are here to advocate for selection of patients that are going to be proper, that are going to meet the criteria, so that way we can really help them and not just dish out false hope, you know. And then tomorrow, Children's is sending me and Midge. Midge is the ECMO coordinator for all of us at Covenant. We're going to Detroit for an ELSO conference, and something cool that happened in Singapore was, so there's Dr. Peek was the author of one of 2 randomized control trials that have ever been performed. A wound care nurse that works in the same hospital as him in Florida was there doing a presentation on wound care for ECMO cannula sites, because bleeding is a huge concern. I don't know if I've mentioned that before, but they bleed a lot from the cannula sites. And so he was presenting some information on the best way to put a dressing on there and even wound vacs, not because they have erosion, but just to control the bleeding, to kind of clamp the capillaries down. Anyway, so we were talking about our posters together, and he was looking at mine and he said, Peak, because he was looking at the references that were cited on my poster. Giles Peak? That's one of the doctors that I work with. He helped me do this study. So they're going to be at the ELSO conference this weekend, so I'm really excited to be able to meet up with them. We have plans to meet up and kind of just talk about things, pick his brain, but you never know what kind of connections you'll make even in Singapore. If you bring whatever your specialty is to the table, you'll meet all kinds of people. So I'm really looking forward to that this weekend. Here are my references. I'm not going to read those either, don't worry. And I'm happy to take any questions that you guys may have.